Hello students, welcome. Myself Dr. Roshini, your OBGYN faculty at DigiNerve. So, since our INI-CET exam is around the corner, we are revising quick questions and quick high-yield topics for our INI-CET exam. So, coming to the next most important topic, that is your amenorrhea. Yes, amenorrhea, though it is common or uncommon in your clinical practice, but definitely there is always a question on amenorrhea in your papers. Okay, so to begin with, amenorrhea. Before that, what is puberty? Yes, in puberty, it is not just about a period or a straight away some point of time. Okay, puberty is a period. Okay, it is not just a point. Okay, it is a period when a childhood is getting transformed into an adulthood. So here we have multiple changes. Like, firstly, there is an accelerated growth. This is the order that it comes in, accelerated growth. Then comes your Thelarche, that is your first recognized change that comes at around your 10 and a half years. The mean age is around 10 and a half years. Then comes your Adrenarche. So Adrenarche is between 11 years and axillary hair is usually grown after 2 years. So first your pubic hair grows and 2 years down there will be your axillary hair growing. Then lastly will be your again and maximal peak growth, and then lastly followed with the menarche. So this is how your normal puberty changes happen. This all will take around 3 to 4 years to happen. So remember this order. This is commonly asked question. The order, first there is growth, then followed by thelarche, that is your breast changes, then is your adrenarche. Firstly pubic hair will grow, then after that your axillary hair will grow 2 years later, and lastly before your menarche there is again an accelerated growth and followed by your menarche. Okay, this is a normal puberty. If somebody is not attained a menarche, that is the first or primary complaint why a patient would come to you. Okay, that is your primary amenorrhea. Before dealing with that, so why a lady should will have a menarche? So that if you divide into four compartments, starting from your uterus being the first compartment, so uterus is the one which will shed the endometrium, isn't it? Uterus being the first compartment, ovaries being the second compartment, and your pituitary being the third compartment, and lastly your hypothalamus being the fourth compartment. Okay, so your hypothalamus will secrete GnRH, okay, gonadotropin releasing hormone. So this gonadotropin releasing hormone will act on pituitary. What will pituitary release? Yes, it will release your FSH and LH. So FSH and LH is released from pituitary, anterior pituitary, okay, and that will act on your ovaries. So what will ovaries release? It will release your estrogens and progesterones. Is yes, no? So if you know this progress, so you can pick up when they give a history, so you can pick up at that time where is the cause for amenorrhea. Okay, that is why I'm telling you all these things. Your hypothalamus will secrete GnRH, GnRH will act on pituitary, and pituitary will secrete, the anterior pituitary will secrete your FSH and LH, that will act on the ovaries, and ovaries will secrete estrogen and progesterone, that in turn will act on the endometrium, uterine endometrium, and then there will be shedding of the blood. So estrogen excess and progesterone excess will give again a negative feedback mechanism to your hypothalamus, and then that is when the bleeding will stop and the regrowth of the endometrium will happen. Okay, this is how a normal cycle will happen. So these are the four important compartments that we are going to deal in further. So next, coming to the amenorrhea by definition, primary amenorrhea is described when a patient who has never menstruated, whereas secondary amenorrhea describes those who have previously menstruated and are now not menstruating. So by definition, what is primary amenorrhea? Yes, primary amenorrhea describes those who have never menstruated at all, whereas secondary amenorrhea is when a person who's already menstruated and at right now they are not menstruating. So by definition, what is primary amenorrhea? By 13 years without secondary sexual characters. Okay, whereas in with secondary sexual characters it is 15 years with secondary sexual characters. So if there are secondary sexual characters, what are they? Your thelarche, adrenarche, pubarche, all these things are there. So there is a breast development, there is pubic hair, axillary hair, there is a accelerated growth of the kid. So that time you can wait till 15 years, but whereas at 13 years with no complaint, with no secondary sexual characters, then you have to start evaluating. But also remember, this age is not right, okay, she's not 15 years, she's just 14 years now, I will evaluate her after 1 year. No, whenever the patient gives a concern of amenorrhea, you should evaluate her, okay, at an appropriate age. If it is a concern for her, it is a concern. You have to examine the patient and give her proper advice. Coming to Okay, coming to secondary amenorrhea. In secondary amenorrhea, 3 months of amenorrhea is there. A person who's already menstruated, but last 3 months she is not menstruating, and also if her last three cycles, if she's known case of delayed cycles or PCOS, if more than last three cycles, okay, for example, if her cycles were 1.5 2 months, so that means you can wait till 6 months because her cycles were delayed. So more than three cycles of a previous regular cycles, whatever it was, more than three cycles or more than 3 months of amenorrhea, then you consider as secondary amenorrhea. So what are the common causes of primary and secondary amenorrhea? So physiological and pathological. Physiological, when is primary amenorrhea? It is before puberty, isn't it? So before puberty they have primary amenorrhea. This also they have asked you, so remember this classification. That's why I've given you this photo. Coming to the secondary physiological secondary amenorrhea causes, yes, like during pregnancy they have 9 months of amenorrhea. During lactation, again during lactating they'll have amenorrhea. Following menopause, after menopause also they have amenorrhea. So this is all the causes for physiological reasons. Coming to pathological reasons, it can be concealed, where there is everything is there but the outflow tract is abnormal, leading to a amenorrhea. So that can be either congenital or acquired. Okay, so congenital like imperforate hymen or cryptomenorrhea, whereas acquired there is stenosis or labial stenosis or stitching, something is happening, so they have a cryptomenorrhea, whereas there is a concealed kind of bleeding is there inside but we are not able to see. Coming to true amenorrhea, it can be again further primary and secondary. So in detail we are going to talk about the secondary amenorrhea now. So in detail we are going to talk about the primary amenorrhea now. Okay. So coming to amenorrhea, now what are the common causes? Yes, we have told you the different compartments 1, 2, 3 and 4. The basic requirement for normal menstrual function includes 4 anatomical and functional distinct structures. So if there is a disordered outflow tract, like we told imperforate hymen, okay, disordered outflow tract or uterine target organ, the uterine, the endometrium is itself abnormal or uterus itself is absent, or there is a abnormal endometrium, or there is septum, anything can be there, isn't it? Outflow tract has a blockage, all these things that comes you in your first uterus, okay, the outflow tract is abnormal. Second comes your disorders in the ovary, like your premature ovarian failure or disordered development of gonads and genesis, like that. Okay, so that comes your ovary, where there is no secretion of estrogen and progesterone. Next, coming to disorders of anterior pituitary, like adenomas, hypopituitary or hyperadenomas in pituitary compartment. Lastly, coming to your central nervous system, your hypothalamus system abnormalities. So how will you interpret them? So this is commonly given reports. They will give you FSH reports, FSH and LH reports, and then ask you what is the cause. So when is it? It can be primary amenorrhea with less FSH and LH also. So if it is less FSH and LH, then it might be in pre-pubertal regions, kids. Okay, before puberty, FSH and LH is less because ovary is not functional yet. Then in hypothalamic or pituitary dysfunctions, it can be FSH and LH is less. Why? Because pituitary is not releasing at all. So there is a pituitary dysfunction. There may be absent stella turcica. So whatever it is, pituitary is not releasing FSH and LH. So there is a hypopituitarism or hypothalamus is not stimulating. So here is the problem when there is FSH and LH is low. Next, coming to normal FSH and LH with primary amenorrhea, that means there is secretion but there is some abnormality. The quantity is there but the quality of the FSH and LH is abnormal, which is not able to act on your uterus or the ovary to release estrogens and progesterone. So it is not acting on the ovaries to release estrogen and progesterone. So biochemical inactive structures, the quality of the module is altered. In such case it can be normal. Coming to high, which is commonly asked, this is what they usually give. High levels of FSH and LH suggest a postmenopausal patient or ovarian dysfunction. Okay, whenever there is a ovarian dysfunction, the pituitary is secreting FSH and LH release over, stimulate the eggs, helps the growth of the ovum, isn't it? But there is no eggs at all in the ovary. That is why it is not able to get stimulated. That is why so much of excess FSH and LH is there. So ideally what should happen? FSH LH will act on the ovaries and the follicles will grow and they will release estrogen and progesterone that will go do a negative feedback mechanism. Since here there is no negative feedback mechanism, estrogen and progesterone are not releasing, so there is no negative feedback mechanism. That is why your FSH and LH is raised. Whenever there is a problem in ovary, there is raise in FSH and LH. Whenever there is problem in pituitary per se, it is low FSH and LH. Okay, this is what you should remember. High serum FSH. A high serum FSH concentration in the presence of amenorrhea is a reliable indicator of ovarian function depletion or ovarian failure. Repeated FSH test has to be done to confirm these findings. Next, coming to anti-Mullerian hormone. This is also recently they have been asking. It is one of the tests for ovarian reserve tests. Okay, so this is a test for ovarian reserve test. So normally it should be around 2 is their value, more than 2 at least, and less than 5. Okay, if it is low, if ovarian reserve or AMH is less than 0.5, that means there are no follicles at all, because AMH is secreted by preantral follicles. Remember, preantral follicles. This is also your question, which is less than 4 mm. So the follicles which are less than 4 mm will secrete your AMH. So whenever there is less AMH, that means the follicles are not there at all. So that is why it is a test for ovarian reserve. Okay, so preantral follicle which is less than 4 mm will secrete this, and a value of less than 0.5 means it is a severe depletion. There is no follicles left at all. Okay, whereas normal 2 to 5 will be considered as normal or good fertility index. Whereas if it is more than 5 and also she is having amenorrhea, then what is it? There are enough number of AMH secreting follicles, but still she is having follicle. When do you have more follicles but good for nothing? It is in PCOS. Yes, correct. In your PCOS, what happens? The AMH levels are very high, but still they'll have amenorrhea. So here they may give you a history of obese patient, and also she's having amenorrhea, and they'll give you infertility, and they'll give you AMH is more than 5. That time it should strike in your mind that this is a case of PCOS. How will you treat? So you should treat with metformin and ovulation induction in a controlled way. That is what you should tell. Okay, this is how the questions will be asked. Next, coming to hyperprolactinemia. In hyperprolactinemia, it is one of the common cause for secondary amenorrhea. Okay, whereas hyperprolactinemia, what it will do? Your GnRH pulsatile release is there, no? So the normal pulsatile release should be there. GnRH doesn't come as a single continuous flow. It has a pulsatile release. That is, a rhythmic flow will be there. This rhythm will be altered by your hyperprolactinemia. Whenever there is hyperprolactinemia, your GnRH pulsatile release will be altered, causing your secondary amenorrhea. If there is hyperprolactinemia during the puberty or menarche period, that time again there will be raised hyperprolactin leading to delayed puberty. Okay, that is what you should check. Coming to mild hyperprolactinemia, the values are 20 to 50. This also is important. You should know here there will be pre-ovulatory follicular defects. Okay, developmental defect. Whereas moderate hyperprolactinemia between 50 to 100, then again you will have oligomenorrhea in such cases, or amenorrhea. Whereas high prolactinoma, which is very dangerous, that is more than 100, these patients will have low levels of estrogen causing osteoporosis, even genital atrophy also. Okay, clinical consequences of genitourinary atrophies and osteoporosis. Okay, this is what you should remember. Coming to the common causes of amenorrhea, again these compartments you should remember: 1, 2, 3 and 4. Okay, so your first compartment, common cause or outflow obstruction, what are they? Yes, Asherman syndrome, whereas there is overzealous postpartum curettage, she had abortions or manual removal of placenta, multiple curettage, then there will be severe adhesions or uterine artery embolizations, or in tuberculosis there is Asherman syndrome. Next comes your Mullerian anomalies, agenesis, maldevelopment, septal defects in such cases. imperforate hymen, vaginal transverse vaginal septum, cervix is absent, uterus is absent in such case. And Mullerian agenesis itself, or Mayer-Rokitansky MRKH syndrome. So these are the common causes, or your androgen insensitivity syndrome, where there is incomplete or incomplete because of this will be actually a 46XY patient but still having female external genitalia because of androgen insensitivity. Next, coming to compartment 2, here is your ovarian development. Your pure gonadal dysgenesis, that is your bilateral streak ovaries, or 46XO may be there, or there may be Turner syndrome, or mixed gonadal dysgenesis, whereas one side the testicular tissue is there, other side streak gonad is there. Phenotype varies. These are newborns with ambiguous genitalia. During the birth, you will not be able to tell exactly. And then XY gonadal dysgenesis, a female patient with XY karyotype with Mullerian system or lack of sexual development. That is your Sever syndrome. Next comes your gonadal agenesis or resistance ovarian syndrome or premature ovarian failure. These are the common causes of ovarian causes of amenorrhea. Please remember all these things. I have written it down so that you will have a picture remembrance in your close exam, upcoming exam. Next, coming to your third compartment, anterior pituitary, as we told, microadenomas or macroadenomas, and also empty cellular tursicate syndrome. There's hypopituitarism. Okay, and lastly, your Sheehan syndrome. This happens post partum hemorrhage when there is PPH, severe PPH, embolism that will affect because of the very high dilatation of the pituitary arteries or enlargement of the pituitary. There is high chance of thromboembolism happening in your pituitary vessels, causing following a postpartum hemorrhage, causing your pituitary abnormal development. So what these patient will have lactation, failure of lactation. So they will not have lactation. Whenever they give you a complaint saying she did not lactate, she did not get enough secretions postpartum, she did not feed the baby, follow she had a PPH, after that she could not feed the baby, and after she never got her cycles, that means it's a clear case of Sheehan syndrome. Coming to the last compartment, your CNS. This is your hypothalamic compartment, mostly your psychological and stress related. So here, hypothalamic amenorrhea, your GnRH pulsatile only is not there. Anorexia nervosa or bulimia nervosa, all your psychological disorders comes under your last compartment. Exercise amenorrhea, inherited disorders like Kalman syndrome or your hypogonadism due to hypogonadotrophic X-linked inherited disorders. Okay, adrenal hypoplasia. In such cases, again, there is very high chance of having a primary amenorrhea, especially very high stress related. You can see athletes or a very active person will be very lean, still they might have not developed your enough fat deposits, or enough GnRH stimulation is not there for it to stimulate the pituitary to release FSH and LH. Okay, so hypogonadotrophic hypogonadism, this is called as. Coming to your quick assessment, if there is a short statured patient with amenorrhea, first common is Turner syndrome, cretinism, Prader-Willi syndrome, and CNS diseases, severe malnutrition. Amenorrhea with obesity, then it is Cushing syndrome, Lawrence Moonbill syndrome, Prader-Willi syndrome, and PCOD. These are the common causes for amenorrhea with obesity. Okay, hypothyroidism. Next, let us end this with MCQs. A 15-year-old girl has not attained menarche. She has normal breast development and pubic hair. Her pelvic ultrasound, uterus is absent. So what is your most likely diagnosis? Absent uterus is nothing but MRKH syndrome. If there was normal breast development and abnormal pubic hair, there was no pubic and axillary hair, then it comes under androgen insensitivity syndrome. But since your pubic and axillary hair is normal, we are going for MRKH. Okay, so in androgen insensitivity, for the hair growth also there is requirement of androgen sensitivity. That is why they do not have hair growth at all. Okay, next, coming to next question. A 13-year-old girl presents with short stature, webbed neck, and delayed pituitary in puberty. Her karyotyping is 45XO. What is the normal level of normal pattern of hormones in her. So with all these things, I'm sure you definitely got to know what is the diagnosis. It is your Turner's syndrome, isn't it? So now you know the Turner syndrome. They will not ask direct question of Turner syndrome. What are they have asked? What is the hormone level? So in Turner syndrome, they have streak gonads. Okay, so ovary is not functional. What about the pituitary? Pituitary is functional, isn't it? So pituitary, FSH and LH will be raised because ovary is not functional. To stimulate this non-functional ovary, the pituitary will be excessively pushing FSH and LH. So there will be high levels of FSH and LH. Okay, high FSH will be there and high LH. So first one will be your correct answer. Next question. A 10-year-old girl presents with early breast development, Cephalus spots, and she has irregular vaginal bleeding. Bone age is advanced. What is your normal diagnosis of likely diagnosis? So there is Cephalus spots with amenorrhea and fibrous dysplasia. Okay, these are three common features. I wanted to tell about this triad. That is why I've given you this question. Cephalus spots, amenorrhea, and fibrous dysplasia. These three are a classical features of McCune-Albright syndrome. Okay, so that is why I gave you this question. Please remember this. And with this, we end your INI-CET quick revision. I hope this session helped you. Thank you. All the best for your exams.